Ladies and gentlemen, greetings. This is Prosthodontics on Friday Night Live, which addresses different steps of prosthodontic treatment as well as its side effects. This is in line with the series Back to the Basics. Today we have Professor Im Young-jun of Graduate School of Seoul National University Dental School, who is going to talk under the topic Solve My Pursed Lips, Defining Vertical Dimension. The professor is going to talk about addressing the functional and aesthetic needs of the edentulous patient. Thank you for coming all the way. Despite your busy schedule, you've previously provided a fabulous lecture on occlusal surface and interocclusal space. I'm honored to have you again. Thank you. Can you briefly explain about today's lecture? Today, I'm going to talk about defining vertical dimension in full denture or full mouth cases. I believe this is one of the most creative aspects of dentistry. I'm going to focus on vertical dimension establishment. It's a very important topic. After listening to your introduction, I have even more expectations for today's lecture. Those of you watching from dental site, you can communicate real time via the chat, leave your questions, have them answered, and then you'll be able to try your chance at winning Starbucks coffee coupons. Those of you who leave the most memorable questions will be selected as best question, and Buse Music Tiger's dental set will be sent to learn about the full denture and try your chance at winning amazing prizes. I look forward to your keen interest and participation, and let us begin Prosthodontics on Friday. The overarching theme is back to the basics. I want to talk about establishing vertical dimension in full denture cases. I'm Professor Im Young-jun. I want to focus on full denture, and I'm honored to be here together with Professor Jo In-ho. I'm honored as well. I want to talk about 5 main topics. There are largely 2 problems in regards to full denture. Imbalance with the facial and lip support and inappropriate vertical dimension. A lot of patients have low vertical dimension. Why is this so? The imbalance with the facial and lip support, as we all know, with lack of lip support and facial support, the lip becomes very flat, especially in the philtrum area. The bone in the upper tends to be resorbed, and in the case of lower, it widens. Because of bone resorption in the upper and lower, inevitably in edentulous patients, a jaw size discrepancy occurs. Theoretically, if we can position the full denture teeth in the original position, then that would become the most ideal denture. However, in many cases, people do not really consider lip support and facial support and do not place the denture teeth in the original position and just position them on top of the ridge. Because of this, we are unable to compensate using denture resin, and the patient loses lip support and facial support. In the case of upper anterior, the position of it is on average 8 to 10 millimeters from incisive papilla. This is well known. We need to stick to the basics as we fabricate the denture. I'm not good with numbers, but I hope you remember this one. 22 millimeter. From vestibule to incisive edge, It's on average 22 millimeters. Please remember this. And in line with that, occlusal rim needs to be fabricated. These days, implant has become center of treatment, but regardless of which implant, regardless of the position, the upper anterior position can be the same. And following that, we determine the treatment plan. In order to secure appropriate position and length, there are different techniques available. However, in essence, the upper anterior needs to be positioned in the same way, or else these kind of situations occur. Implant is positioned gingivally, and because of inappropriate vertical dimension, the prosthesis looks like a banana. They're enormous. In order to provide vertical overlap and overbite, it looks like banana. The second question is, why do many denture patients have low vertical dimension? The reason is probably this. In the case of low occlusion, there can be many problems, but compared to when it is set high, there's less pain and patient can really adapt to it more easily. Conversely, if the patient has a high vertical dimension, on the day of denture delivery, patient may return. The patient may not have even left the dental clinic before returning. In other words, if you have a high vertical dimension, the patient will be unable to use it because there is a very small freeway space, and the patient will look very unnatural in terms of appearance and will experience many discomfort. Therefore, delivery itself becomes impossible, and that's why many patients have low vertical dimension. In determining vertical dimension, I believe this is the most important process among denture fabrication. And this is an area where dentists can be really creative. Depending on patient situation, the dentist can be more creative. Nothing is defined. Depending on the surgeon, different ways to address it can exist. Many people have talked about different ways, and today I want to explain about the method using freeway space, phonetics, Willis theory, and McGee theory. I'm sure you are all aware of freeway space when the patient is clenching and is at rest. As I'm giving my lecture, as I speak, the upper and lower teeth do not come in contact. The freeway space is known to be 2 to 4 millimeters on average. Finding the right freeway space, I think this is one of inaccurate methods. There are many methods available, such as G2. When a person speaks, you can visually check a freeway space, and video can be set in this way. This may be the most convenient way. In talking about freeway space, I hope you remember the fact that as you get older, the size of a freeway space becomes bigger. In the case of a young patient, on average, the range is between 2 to 4 millimeters, but in the case of an elderly patient, it can range between 5 to 10 millimeters or more. Therefore, we need to take note that freeway space increases with age. In other words, VDO becomes reduced, and that can be more comfortable for the patient. Please remember this. When I ask my students, how do you find the VDO? Many say that they use pronunciations. This is about the closest speaking space which we learned at school. You have the patient pronounce F and V. Is this really possible? Is this clinically viable option? Such doubt does come to mind. So A very famous concept was introduced in 70s and it's been about 50 years. Earl Pound and George Murrell introduced this kind of way in finding video with pronunciation. In the upper, be it wax denture or existing denture, with the 6 anterior aligned, you have the patient pronounce S. They have proposed a speaking wax, which is shown on the far left. It looks soft and white like Iowa wax. You put it in oral cavity and you have the patient pronounce S words like Mississippi and Sussex. In the area where it is in contact, as shown in far right, it is removed and closest to speaking space or S position is found. The 4 lower anterior teeth are set up using midline as basis. In the case of upper anterior 6, if possible, I think it would be best if the dentist sets the 6 anteriors at chair side looking at the patient's face, but this is unrealistic. We don't have enough time to spend to set the 6 anteriors chair side. So how do my students get it with the pronunciation? Evaluation of S pronunciation can really be of help in getting VDO when we reach the wax denture stage. If a dentist cannot align the 6 anteriors chair side, my suggestion is to make a occlusal rim. You can do this by training your staff. By utilizing anatomical statistics, you need to make a occlusal rim in a very good way. You can make slight adjustments before setting on a patient's oral cavity. There are many references, anatomically speaking. In the case of maxillary vestibule, from the deepest vestibule to incisal edge, as for foreigners, it's 21.3 millimeters, and for Koreans, it's 20.8 millimeters. And if you look at the context, we can make it 22 millimeters on average. This is when my students do hands-on. What is important is that we need to make it 8 to 10 millimeters anterior to incisive papilla and make it 22 millimeters. You need to make accurate wax rim and adjust it intraorally. What I hope you remember is 22 millimeters and 8 to 10 millimeters. In the case of upper posterior, it should be 18 millimeters, and in the case of lower anterior, it's 18 millimeters, and I'm sure you could be able to do a good job in the occlusal surface. It's the same with lower. The position of the labial incisive surface of the lower central incisor is the deepest in lower vestibule, and it is common sense that occlusal surface needs to be positioned between half and 1/3 of retromolar pad. I'm sure we are already aware of lower incisor edge, and making good articulating paper is essential in reducing time when you make adjustments intraorally. You can use a ruler, you can train your staff. We need to be fully aware of the several principles in determining the occlusal plane, and we need to use Fox plane. The Fox plane is parallel to campus line, allotragus line, and occlusal surface. You can buy a Fox plane, or if you don't have it, you can use a ruler. As shown in this image, you can use a wooden stick. I brought this image on purpose. You need to check occlusal plane, and it's of very good help. You can use a ruler and do it vertically, or you can use a wooden stick. It is very important to get the right occlusal plane for the upper. This is a very famous JPD literature published in 1978. This is my interpretation. As for upper anterior, the upper central incisor becomes more hidden with age. On the other hand, as for the lower anterior, the mandibular central incisors are more prominent with age. Yes, the upper anterior 6. With age, you would not be able to really see it. Conversely, the teeth and the lower becomes more prominent. What does this mean? When we treat elderly patients, we need to make sure that teeth do not become too prominent. Yes, there's a difference between gender and ethnicity. In elderly patients, aesthetically, it is not favorable if too many teeth are showing. As shown on the right, if you look over here, we need to make adjustments on occlusal rims so that teeth are shown as displayed. Teeth should be shown less than 2 millimeters, said Hartwell and Run. As for the mandibular articulator, this should be in line with determining the occlusal plane posterior to retromolar pad, and when the patient is at rest, the oral commissure should be barely visible. Using these references, this is not just for full denture, but also when you do full mouth restorations, you can utilize them. These are checkpoints that are very useful. In upper and lower, the height of the upper, we understand this part, and we understand the entire height, occlusal plane, and posterior limit. With the anatomical structure in mind, if you understand the overall limit, you'd be able to check all the marks in doing full mouth restorations. Third, you need to fixate record base intraorally. Occlusal rim, when you fabricate it, you use wax and undercut to block out on the record base itself, so at times it is not easily fixated intraorally, so you spray some water. If you do different steps, at times it can fall easily off. Occlusal rim can fall off easily. In the textbook, some people say you need to use a fit checker. It's good, but it's expensive and some may find it redundant. The position of record base is very important, but it's difficult to get. My recommendation is this. If you have denture adhesive, you can use it to fixate record base. It can be of great help. You need to do all you can, and with the record base fixated, you need to register the upper and lower bite to get good results. Fourth, extraorally, you need to apply the theories of Willis and McGee. This is something we already know. At the very top, there's two lines, this one and this one are the same. What McGee is saying is that F to H line and E to G line. Two common grounds exist between Willis and McGee theory. According to McGee, at least 2 out of 3 needs to be aligned. Intraorally, after adjusting occlusion with occlusal rim extraorally, you need to use the ruler. You need to at least roughly check whether these positions are the same. You need to give that impression that you're doing everything for the patient. And it can be of great help. I went backwards. There's 2 more things. So first is that in chair side, you need to check interocclusal clearance. This is very important. Second, You need to make a thorough observation of the existing denture if there is one. You need to observe, examine, and supplement it. This is essential. I think now you're going to about to move on to centric relation, and before that, in terms of vertical dimension, determining the lip support and lower third is very important, and I would like you to accentuate this point once again before we move on. Understood? We need to utilize anatomical references so that the teeth are positioned in the original position in the upper anterior. It needs to be as close as possible. We need to pay a lot of attention to it, and in setting VDO with the age, we need to consider that the freeway space increases. Extraorally, you need to apply Willis and McGee theory, and it is important to get the right occlusal plane. What is most important is to examine the existing denture well. You need to look at the pros and cons. If there are any disadvantages, we need to supplement it and reflect that into the new denture. So I would like to summarize like this. If you look at the existing denture, you need to ask about the denture to your patient. Yes, it's important. You need to ask whether there are anything to improve to the patient, and I think that'll be better. From a dentist perspective, you need to look at the previous denture, and if it is excellent, then you may not want to get involved. That is a decision that we can make. If the denture is roughly made and if it doesn't really look right, if you think that you'll be able to do a much better job, then it can be also a decision. So looking at the existing denture is essential. The response from the viewers are very hot these days. There are many comments and questions on chat screen. I look forward to Professor Lim's lecture. Go, Professor Lim. There are many words of encouragement. Thank you. Let's learn hard. I've heard that a lot of people use a Venus gauge in determining vertical dimension. Do you use it, Professor? Venus gauge. Yes, from the chin, you use it. It's excellent. If you have that tool within the oral cavity, you can measure the different numbers mentioned in Willis and McGee theory. And we can inform the patient that we're using different means to improve the patient's facial profile. Using these tools are really excellent. The ID name is Let's Learn Hard, but you're already doing an excellent job. Understood. There are different tools that help in determining vertical dimension, and utilizing these well can be of great help. Yes. Study hard. Another question from this person. When we make wax rim upon try-in, it fractures easily. How can I address this? Paraffin wax, there's a hard one, and there are different types. Perhaps this person has used the hard one. What's your take on it? As wax rim is fabricated, there are many layers, and in general, it needs to be prepped. And if heat is not sufficiently applied as you adjust it, I don't think wax itself fractures. So the layers peel off, and more so than desired, the amount that is removed becomes significant. So this person probably did not do he or she themselves, and the lab did not apply sufficient heat. So in that case, it fractures easily. You need to deal with it properly. If this fractures or crumbles easily before you do it, you can use torch and apply heat, then such instance will be reduced. Question from Light. The average distance between nose tip and mentum is used to set VD randomly for the anterior area. So it may differ depending on different individuals, right? Should I use the position where the upper and lower lip is in contact upon rest as a reference? Regardless of the technique you use, there is no one size fits all. What is important is how the patient adapts and accepts it. I always say this, when we fabricate denture, it's our work when we make it, but after the work is complete, it's up to the patient. You need to reference different anatomical indicators, but you need to adjust it intraorally, and you need to make it harmonious with the patient, and that is most important. ID Pang Pang. If the patient has been using denture with a very low VDO for a long period of time, when I make a new denture with a normal vertical dimension, patient complains of discomfort. This is an excellent question. I say like this: textbook denture and handsome denture. This is how I refer to them. If the patient has been using denture with very low VDO for a significant period, based on our academic knowledge, if we increase the VDO significantly and do maximum coverage, then the denture base will become larger. The patient will not be able to adjust to it and will be unable to use it. The patient will complain of how their mouth feels full. In the end, your huge restoration becomes small, just like the denture you found to be ugly in the first place. As mentioned earlier, I've talked about two things. Free waist space increases with age. So in wax denture stage or occlusal rim stage, you need to receive patient acceptance, and you need to increase it less and increase the free waist space. In other words, VDO is lowered, and you need to replicate the existing denture. You need to think of these points, and I think this will help you reach to a solution. This can be an issue in a lot of cases, and I've experienced cases where I've refabricated dentures to my patients. So I've had many experiences because the standard that we have from textbook about denture and what the patient wants vary. If you have a lot of experience, then you may think you need to do certain approach with this patient, but if the patient does not have a lot of experience and is treating just based on what he or she has learned from textbooks, then what should they do? What kind of evidence can they use in determining whether or not to reduce VDO for certain patients? Because denture fabricated based on textbook knowledge would just simply not work here. The best way to do it is to look at the existing denture. I'm sure everyone has many clinical experience, and I'm sure everyone is renowned. I'm sure you're very knowledgeable based on your clinical experiences. Let me ask you a question. Who use denture better, people with ridge or without? I have no clue, but people without a ridge tend to use denture better. In other words, the know-how of the patient and the neuromuscular system adaptation plays a massive role in the quality of the denture and how the patient uses it. There are many cases where there's practically no ridge. When there's severe resorption, It looks almost concave. When such patient comes in, a part of me thinks, I cannot do this, but as I speak to the patient and as I listen to the patient talk about how many dentures the patient has used, then in a lot of cases, I come to think that perhaps I could do a good job here. And actually, the patient uses them well. Let me give you an example. When you look at a beginner riding Mercedes-Benz and a person who's been riding a cheap car for over 30 years, the driving skill itself would be better in the case of a person who has had 30 years of driving experience. That is so true. I think you need to keep this in mind. Next. Bright St. Mary's Dental Clinic. I've been looking forward to today. I look forward to Professor Joe. Nice comments. Thank you. Study hard in a different lecture. The more the teeth become visible, the patient looks younger is their average figure for different age groups. This was lightly addressed previously. Just because teeth are more visible, it doesn't make a patient look younger. Young people show a lot of teeth, and this was partially addressed in my lecture, and as I summarize, I'm going to touch upon it once more. Okay? Light. When we increase vertical dimension when fabricating new full denture, we will not be able to increase it infinitely. What is the limit? I understand that 5 millimeter is the limit, but up to what point can we do it? We discuss about 5 millimeter, 4 millimeter when the patient has teeth wear or if the patient is partially edentulous. When we increase vertical dimension, we need to understand the limit, and this is normally based on freeway space. Increasing VDO too much or not increasing VDO. They both can have issues. They can involve TMD issues. With more resorption in the case of edentulous cases, you want to increase the VDO because jaw size discrepancy is reduced. However, we cannot increase it as much, and we need to do it within 5 millimeter. Depending on the freeway space and the level felt by the patient, we need to make adjustment. If you increase the VDO significantly in the case of female patients, they don't want their lips to look as wrinkly. We need to consider function as well as aesthetics. Grape tree in gingival-labial fold up to the incisive margin of upper central incisors. You've mentioned that 22 millimeters is the average. This could be the canine as well. That being said, is the starting point the deepest part of anterior area? When taking snap impression, the tray moves towards the surgeon and the vestibule depths can change when impression is taken. That is the question. The first part, the incisive margin, up to the vestibule, the deepest part of vestibule, it is 22 millimeters on average, and you remove 1 to 2 millimeters depending on the patient. You may at times increase it, but most of the time it is reduced. I'm unsure of what this person means by snap impression. I think this person is talking about individual tray. When taking individual tray impression, the vestibule depths can change with impression. So to prevent it, border molding is done and removal is done. In most cases, people use alginate for taking impression in full denture cases. Alginate cannot prevent that, therefore, in general, extension becomes very long and you need to make consideration on that. Yes, that's true. You need to do muscle trimming to minimize it. I think this answers your question. Also, before taking impression with individual tray, you need to practice a lot. And this is frequently discussed. Where it should be positioned. There are many more questions, but because the professor needs to carry on with his lecture, we will first listen to your lecture and then entertain more questions at the Q&A session. CR guidance and record. I'm sure you're aware of this. I want to talk about CR guidance and about bite registration. I think this is like a bullfight. Bilateral balanced bimanual. What I want to accentuate here is that this needs to be done under the lead of the dentist. As we move backwards, the patient comes forward almost like a bullfight. I always tell this to my patient. I always tell this to my students. So if a student has an opportunity to make my CR, then it will be very easy to understand. So the student is going to ask me to close in CR. And then I'll be able to understand and do that, but that's not the case for the patient. The CR manipulation needs to be accurate and guidance is very important. I normally have the patient tilt the head and then do it. There are many different ways. I want to highlight that you need to provide massage and have the patient to relax. You need to tell them to relax and to leave everything to the dentist. So you need to have the patient relax and let the dentist close mouth. When doing bite registration, clenching is not really good, so it needs to be in natural contact. This needs to be done under the dentist's lead. There are many ways to do it. We try to push posteriorly and the patient tries to protrude it as much as so. I'm sure you'll be able to read about it. What I find most funny is number 1. So when the patient is unable to do it, you need to push your upper jaw, then you get the same result. As you know, the upper jaw, it's fixated on the skull, so you cannot move it actually. So all the movement is related to lower jaw. So this is important. In doing bite registration, what is most important is to use a zinc oxide impression paste. This is very difficult to manage, and once it gets on your clothes, it's very difficult to remove. And in the past, we used to use this for taking impression. Gun type, it's good, but inevitably a bit of error occurs. So what you use most frequently is aloe wax. What is most unfortunate is that after you make a wax rim in the posterior area, in order to put in bite registration material, you remove a part of it and you remove the accurate bite registration of the upper and lower relations later. And this is the toughest part. And it's really difficult to control the patient so that we get the right CR. When you look at full denture cases, this kind of idea was available. So you use a staple and use a hot alcohol lamp together, and this is fixated. So you get the upper and lower information at the same time. In some sense, it's very good. I'm going to show you this video later. After all the work we put in and getting the right bite registration, you take it out and remove the posterior area. If we can use this and keep it, then it'll be great. You can make it slightly hot like this and make small lines. And this was in the textbook. I was so happy to find this in the textbook. So you can at once connect the upper and lower as shown. This is something you can consider. In the case where guidance is difficult and if you have gained bite registration in a very difficult way, and if the bite is not reproducible and if it continues to change, perhaps you can use this technique. I'm going to show you a video clip of how the occlusal height of the upper and lower is determined. Determining the vertical dimension of upper and lower and taking bite. I'm going to move through very quickly. It's very important to look at the existing denture. The amount of height in the existing denture, and you need to ask what kind of discomforts the patient had with the original denture and what kind of teeth the patient has been using, whether the patient is satisfied with the size, how it was when the patient chewed, were there any problems. So there are so many information you can get from the original denture, and you put the wax rim in the oral cavity. It's almost as if this has been staged. This is the height. Wax rim is adjusted and anatomical positions are marked, and you can see that the mark is about 8 to 10 millimeters, and wax rim is nicely made, and now it goes into the oral cavity. Oopsie, a bit of a problem here. I've tried to skip fast, but now it's going to take longer. Shift. I'm going to just push forward. I have a lot of things that I want to share, so I'm now measuring the length. I'm now doing the measurements and adjustments are made. Occlusal rim. I'm sure you're all aware of this. I'm going to skip through it, and the measurements are made for the lower occlusal plane, and now upper and lower occlusal rim needs to be made properly. After that, what should be done? Fox plane is going to be used for occlusal plane. Upper and lower 22 millimeters and 18 millimeters in Fox plane. Allotragus line, occlusal plane. Regardless of the method you choose, it is very important to take measurements. Very good occlusal plane leads to excellent full denture. I am removing sharp bits. Rim is set. I'm not aligning the upper 6 anteriors. So once the patient closes mouth, it's like this. You need to determine whether you're going to trim, and then you're going to make adjustments. What you need to prepare in this stage, you need to do slight melting, and you have the patient close mouth, and in the area where it hits first, the wax is removed. Like this. This is what we're used to, and this goes without saying. If you do it at once, then it'll be of help. Upper and lower, it goes in like this. Upper and lower, in the area where it's high, adjustments are made. What I want to really recommend is to use articulating paper when adjusting wax rim. You can use this. It's of great help. Articulating paper can be applied not just on teeth and fixed prosthesis. Once we're getting close, I thought the upper was slightly low. I'm going to make further adjustments here. Articulating paper is used. The patient closes mouth, and where it's high, it's marked. It is marked. You need to have evidence, so once you use articulating paper, You can see the marks here. You can see the red, and in that area, you just grind it off. It's natural and it's of great help. And you can see that the upper and lower wax rims are in tight contact. You can melt it, and this is my favorite way to do it. I used my 2 fingers. I put it in the patient's oral cavity in the last step. You need to have a little bit of a gap on left and right in order for the patient to be able to use the denture appropriately. Is my finger too thick? In this stage, put the finger inside. It may be a bit salty, but 3 fingers don't go in. You need to make adjustments so that 2 fingers can go back and forth. So I want to ask you 2 things. So when you send it to lab, you need to mark whether it's female or male. Also, patient's age should be marked because the lab needs to know this. You need to mark it, and this is very important. You can see that I'm telling the patient to be careful here because it's very hot. I'm warning the patient because it's hot. The patient's lips need to be reflected thoroughly. You need to do it thoroughly. You need to tell the patient not to move, and you need to warn the patient over and over again. You need to spray cold water. It may feel like it's not going to come off at once, but it does. Do not worry at all. Just fixate it strongly. You need to make sure the tube does not move, and fixation is necessary. And cold water is used here once again. I'm going to remove it, and you can see that it comes off. I think this is a good way to go forward. In the past, people wrote me a poem and gave me this present, and I remember this patient. It was an older patient. Looking at it, the patient has gifted you a poem. It's a great poem. A smile of an elderly. It's very difficult to receive such a high compliment from the patient. So this really drives us to work harder. What did you feel like? I was sort of caught off guard. At first, I thought what I've done wrong, perhaps what you've done right. So I thought long and hard as to how the patient could use the denture well. So I continued to think about how the patient can use it well and repair it. When I receive such compliment, I feel really grateful. I'm honored. This person was one of the memorable ones. Congratulations. Is there a little bit more left on your lecture? Yes, let's take a look. In full denture patients, the amount of time necessary to set the denture and the masticatory efficiency depend on the quality of vertical dimension according to this literature. It's very interesting. Vertical dimension has a significant role in the overall patient satisfaction. 2 surveys were performed. 2 different groups were surveyed. First was the patient themselves, and second were their associates, like family members. When VD was restored, the patient's aesthetic satisfaction level was about 80%. People thought that the patient looked much younger. If you look over here, and this is a very good situation for the patient and for me. When VDO is appropriately restored, about 80% responded positively. Then, how young would the patient look? How many years younger? So you can make them look at least 5 years younger. Some people say 10 years, but 5 years is sufficiently possible. So it had more positive impact on older patients. It's the same. It's a foreigner. It's in the textbook. You can see how whether the teeth is shown or not makes a very big difference. When teeth are not shown, it almost feels as if she's angry. This procedure is not just applied in full denture, but you can utilize it for full arch restoration, so where clinical technique and decisions are required. In treating elderly patients, I do not believe that you require a special technique. You need to be considerate of the patient. You need to relate and form a consensus. With that, you need to come up with an appropriate treatment plan. In the case of elderly patient, solving problem is a series of finding the right compromise. You need to listen to the patient and you need to find the right balance between the dentist and the patient in order to get good results for both dentist and patient. Thank you. Thank you for the wonderful words of wisdom. When you provide a treatment to do a good job in full denture, you need to love the patient. You need to care for the patient. You should not think of the patient as an enemy. You should not worry how much this person is going to cause trouble. But you need to think of the patient with love and care. And when you provide a treatment with such mindset, then you'll be able to get good results. Yes. Thank you for the wonderful lecture. Now we will entertain the rest of the questions. Let's address rest of them. Along with my son, by making the upper anteriors show less, how can I apply 22 millimeter of wax rim height then? When you first make a wax rim in 22 millimeter, you need to do try-in. And in these cases, you remove 1 to 2 millimeters. Grape tree. There was a case where when I placed the occlusal wax rim with an oral cavity, the wax rim was covered with the upper lip. For incisal view, what if I fabricated over 22 millimeters for the patient to look younger? It's give or take 22 millimeters, and you need to adjust accordingly with the patient situation. Our facial length and form are all different, and 22 millimeters is an average figure, and depending on the patient's face and depending on the situation, it may differ. Thank you. Next, good evening. If you use Willis method, A equals B, and if you do this, vertical dimension becomes a high. Do you agree or disagree? If you use A, B, it's high. It may differ depending on the situation. What is important is that A and B should not be equal at all times, and you need to look how harmonious it is with an oral cavity, and you need to check whether the patient is experiencing any discomforts. There are many questions. Thank you. We have to answer them all. Because of time constraint, I feel a bit rushed. The patient has been using existing denture, but it does not fit well when you fabricate fresh. If you make the vertical dimension the same, at times the patient complains of TMJ pain. Is there a solution for it? It's very difficult. Theoretically, in TMJ treatment, you need to increase the VDO. If the VDO is too low, you need to tell the patient that you're going to make it a little bit high. That can solve the problem. And there are cases where it doesn't. Rather than just increasing the VDO blindly, you need to be more flexible depending on the situation. Because the VDO is lower, increasing it slightly, it's quite unscientific, but you need to slightly increase it. It may be related to vertical dimension, but you also need to look at occlusion. You need to check it. You need to check lateral occlusion and CR and check whether there are any issues. When the environment changes, the patient can experience discomforts and there can be TMJ pain. If there's no occlusal issues, then with time we can just wait and see. This is a grape tree. Wax rim is made of flat wax, so upon trying in, the wax of upper and lower are in contact, so the occlusal wax rim can be deviated. When you determine a vertical dimension, it's the same with the CR. You make the lower occlusal rim slightly lower and then you use a 4-cone shape. Are there any precautions or checkpoint? Using cone, there are advantages. I do not recommend a narrow cone. When the occlusal rim is overall flat, many people find it hard to close their mouth. And in such cases, it is difficult to give guidance, so you need to make it larger. You can use a wax bump, and that could be a good tip. I've used it once, it's good. Gil Hospital. This is not a question. Words of encouragement. So this person has said that today's prosthodontics on Friday is very interesting. I love the car innuendo by Professor Joel. Can you tell me the know-how for taking VD and CR? The questions are split. The know-how to get VD and CR. You need to overall look at what's been made thus far for VD. You need to utilize the patient's existing denture. I think the tip is to make it slightly lower, because if it is higher, the patient will not be able to use it. The difference should not be significant. In the case of CR point, depending on different situations, it can be quite complicated. If the vertical part of VD becomes gone, then muscular atrophy occurs and there can be gaps. In other words, CR bite is not consistent and there are people who show stark differences. Like monoplane occlusion, even if you don't use 0-degree tooth, you can grind it off so that you can provide additional space. This is important. In the case of CR, I have the patient lie down. I have the patient relax. And under the control of the dentist from the back, the patient closes mouth. Rehearsal is done several times. You have the patient relax. And the registration is done so that force is applied so the patient cannot close mouth. Angulation. It's difficult to read. If the patient has weak ceramic teeth, then the patient can adjust to occlusal adjustment easily. What is your preference? I think this person is talking about artificial teeth. When using artificial teeth, perhaps you can use a less hard one. In the case of porcelain dehiscence, there is a clicking sound and at times the patient cannot really adjust well. In the past, when we learned, porcelain tooth and resin tooth were available. Porcelain tooth is no longer used, and as for resin tooth, reinforced resin tooth are used frequently. Ceramic teeth, it's rarely used these days. Wonderful. If there is discrepancy between alveolar height because there is time difference in terms of extraction, is there a tip to get the right vertical dimension? At times, the denture is tilted one side, so there's more resorption on one side compared to the other. Vertical dimension, it's not a problem. The final prosthesis can be a problem. In the case of older patients, you can see a lot of such cases, and inevitably, at times you need to make one or two crowns for certain teeth. My recommendation is to prep a partial tooth. In the area where there's interference, removing that bit will make the occlusal plane more comfortable for the patient. That is most important. In that case, a single denture. So the lower would be natural teeth and the upper would be denture, and it could be the other way around. And if the patient has been a dentulous for a long time, such instances can occur. Bora. This is a recently failed case. The patient wanted to use a denture that he has been using for a long time, but from height to teeth alignment, it was very impossible to replicate, and the lab technician had a tough time with it. What is a tip to make it exactly the same? I think this is an excellent question. If the patient has no issue using it, then replicating the existing denture is the best way. Can you replicate it? Yes. There is replicated denture. This is something you replicate the existing denture, like making stent. For implant placement, acrylic resin is used to fabricate, and this is used as record base. And master cast can be fabricated. As you remove each original tooth one by one, you can make it very similar. Also, you can utilize an oral scanner, and there are ways to digitally replicate the denture. This is very important. The patient is used to it, so it feels very comfortable and beautiful. Like the old denture, it may look ugly, but it is very comfortable for the patient. The old denture is the best. Replicating it is a very great idea, and if you think more on this, you'll be able to get good answer. If you're interested, you can reach out to Professor Im Young-jun and communicate on it. Grape tree. Do you use Gothic arch tracing when you do CR guidance? So what is your tip? Gothic arch tracing in getting CR is the best and well-known way. You can do it extraorally and intraorally. And there are different applications of using Gothic arch tracing to get CR, and there are different tracing available. And it does help, but it's not easy to train the patient. To utilize Gothic arch, it takes time. In order to get a CR accurately, Gothic arch tracing is valuable and it has academic significance. It does take a significant time, and you need to provide a thorough orientation to the patient. These are the pros and cons. When you do Gothic arch tracing, wax denture or occlusal rim should be stable. It should not be moving. And as mentioned, you need to have the patient to practice protrusive lateral movement. This should be practiced. 1편, full denture is very difficult. Yes, it never gets easy. Professor Lim, you're so humorous. When I looked at the video clip, the tool looked really hot. Will it be in contact with the lip? You need to pay a lot of attention to it. So Pang Pang, is it sufficient to use an average articulator for mounting? It's not sufficient, but it's perhaps okay. Yes, I agree. Grape Tree has expressed gratitude. This person has left a lot of questions as well. Grape Tree for VD maintenance is hard composite resin tooth from the vendor better than the soft tooth. By hard tooth, I think this person is talking about composite resin tooth coming from the vendor, and for the soft tooth, it feels more soft than that. Is the hard tooth better? Because it can prevent wear, I think it's good. Yes. There are many questions. Gutta. If after try-in, if the full denture does not fit well, can you explain about how to do remounting? When it does not fit properly, I think this person is talking about adjusting the inner surface. After try-in, occlusion is not right. Remounting, I'm unsure. Remounting itself, it takes a lot of time to explain. Simply put, you need to check the occlusion of upper and lower, and in most cases, it can be resolved, but also it cannot be so. You need to do upper and lower separately. If it moves too much and if the inner surface have a lot of issues, you should not think of upper and lower, but you should focus on positioning it right. And be it relining procedure for the lower or other techniques, you need to do that. You need to make sure that bite registration is done properly. Regarding remounting in oral cavity, you can solve it by tapping on it. And there are also many problems associated with the occlusion. I think this person deals with such cases a lot. Professor Lim, you're the president of Korean Academy of Stomatognathia Function and Occlusion. Yes. I'm sure you're interested in occlusion. Bright face, in general, female patients do not like lip protrusion. So I tried to remove the buccal side of the wax rim that has been delivered from the lab. In the case of anterior 6 for female patients, I place it and then send it. What kind of factors do you consider in terms of gender? Bright face, this person is aligning the anterior 6 chair side, and this is amazing. I would like to give you an applause because this is not something that is easy. In the past, patients suffer from depression when they didn't have their dentures. More seasoned dentists would make full dentures in their spare time in the old days. It will be of definite help if you consider the anterior 6. After that, what other factors should we consider in terms of gender? The tooth size should be smaller and more round. It needs to be in harmony with the face. And in terms of color, you need to make it similar to the existing denture and use it as a reference. Pretty Wife, IBH 7575, the difference between having the patient lie down and stand up. Lying down and standing up. In my opinion, in most cases, about 80-90% of the time, there's no issue. Regardless of whether you have the patient lie or stand, it's not a big issue, but some patients, if they were to have problem, then the discrepancy is quite significant, and CR range is very significant, and these patients suffer because of the discrepancy between CR and CO. How we can have the patient adapt more, and depending on whether it is reproducible, you need to choose whether or not to have the patient lie down. In this case, a long period of occlusal adjustment may be necessary. Bright face, thank you for the wonderful lecture. I have new confidence in doing full denture cases. We are very proud to have given you confidence to a fellow dentist. Thank you. Thank you, Professor, for all the comments. Because of time constraint, we were unable to address them thoroughly. I would like to express my gratitude to those who have left questions. Now, Professor Lim, could you choose the person who has raised the best question? Many people have raised many wonderful questions, and I'm grateful for that. It's really getting late. I think being a dentist is really tough. You're busy treating, studying, and watching programs. Thank you. I would like to choose a grape tree because this person has raised a lot of questions. My pick is the grape tree. So is there another person you'd like to gift? I believe everyone continues to learn as they live through life. I hope we can send a coffee coupon to study hard. Study hard, okay. In light of that, I will continue to study, and I will continue on with my research and study to be of help to my students, to everyone. Thank you. The lucky winner today is Grape Tree, and Study Hard will also receive a coffee coupon because Professor Lim has made such recommendation, and we will follow through. Individual contact will be made to those who have been selected as best question, and those who have been selected as coffee coupon winners will be receiving a text on Monday. It's getting quite late, but can you give a word of advice to your peers who are studying hard about full dentures and vertical dimension? I'm honored to have received so many questions and so much interest. I think that being a dentist is really difficult. I've talked about this earlier, but you run your practice and managing the dental clinic, it's not easy at all. I think running your private practice is the epitome of being a dentist. I think the best advice you can give to a dentist is this. For this year at least, hopefully we'll be free of patients that stress us out. That is my hope. Good luck, everyone. So it's not being stressed because there are so few patients. It's about not getting stressed by explaining about vertical dimension well and not getting complaints from the patients, right? Yes. Professor Lim, thank you for coming here despite your busy schedule, and you were really full of wit, and I'm honored to have you here on Prosthodontics on Friday today. Dear viewers of Prosthodontics on Friday, how did you like the Prosthodontics on Friday seminar with Professor Im Myung-jun? I believe today's seminar allowed us to get meaningful tips on full denture and establishing vertical dimension. For questions unanswered today, we will respond to them via reply in the next lecture. This is also about full denture. Professor Do Kwan-tae of Kyung University is going to talk under the title My Denture Slips Upon Mastication, Establishing CR and Vertical Relations. Thank you for staying with us up until late. Thank you.
감사합니다. 자, 아린 교수님, 네, 진짜 감사합니다. 수고 많이 하셨습니다. 네.